much for the Council of IMECS for this kind invitation. It will be difficult to speak after Professor Ali about keratoconus, but I will try. So I will speak about our experience of Corneal wavefront guided PRK in keratoconus. I have no financial interest in this presentation. So it's as told before, it's a surface ablation using excimer laser to treat keratoconus, and it can be associated or not with cross-linking. So what is the goal of this treatment? The first goal is to reduce high-order aberrations. So because the keratoconus is a distorted cornea, so the high order of the eye are coming from cornea. So we will try to reduce corneal high-order aberrations. And we will use corneal wavefront guided, not topo guided. Not topo guided. Topo guided is the data is coming from the anterior surface of the cornea. Here, the data is coming from the whole cornea, anterior and posterior surface. So the goal is improvement of visual acuity, visual quality, and to improve results of other surgeries as cross-linking, intracorneal rings, phakic AOLs in this indication, and reduce the dependence of rigid contact lenses. It's not to get rid of, but to reduce. We have not to promise to patients that they will get rid of this contact lenses, which can reduce. The target is not a refractive surgery, it's a therapeutic surgery. So indications, it should be stable keratoconus. Pachymetry, it should be more than 450. It's not a dogma, we can go less. Kmax should be not very high. And asymmetry between 2 points in the cornea at 5 millimeters should be less than 10 diopters. And the patient should be requesting. You cannot do this to all patients. The patient should be requesting a surgery that enhance the vision. So the patient selection, I will put a red color on psychological profile. So the patient should be requested, and it should be understanding the results of this technique. So the technique should be not a normal PRK, but should be a trans PRK, because it's two PRKs. You have the PTK and wavefront guided PRK. So it is two techniques in one. So the keratoconus is an irregular epithelium, and we cannot remove it with a brush. We should do a PTK before. So in some devices like Schwind, you can do all in one time, PTK and PRK. So this is the well-known theory of early keratoconus. We see that in early keratoconus there is a change in the epithelium. So in our planification, we should do PTK and PRK. The timing of cross-linking can be before. The patient can have cross-linking before, then PRK, or if he hadn't cross-linking before, he can do it in the same session. We use the both technique. So ablation profile tends to flatten the steep area and to steep the flat area to get a cornea more regular. And the treatment of ametropia, meaning myopia or astigma, is not a priority, but we can do it when it is possible. So this is a small video that shows animation, technique. So never remove with a brush or mechanically. We should always do it in trans PRK. So this area is more, we flatten this area, and we get this area steep by flattening this periphery. Should the cylinder be incorporated into treatments? There are some doctors that put refraction 0. I don't put 0. I put some refraction, and I can put the cylinder within certain limits. So there are some ablation profiles in Schwind device. So we see that the profile is not regular, as the keratoconus is not regular, and we can put some refractions here. So it is not 0 here, but I have some limits. The limits are, I do not go more than 50 microns ablation. I don't I don't take the keratometry postoperatively not more than 49, and I try to have an RSP more than 300. So I try to manage the optical zone, the centration of the treatment, the thickness of the epithelium to have these results. This is a video of the technique, so it's no contact. Just with my fingers, I open the eye. It takes some seconds, and then we go to cross-linking. The work is not on the OR, the work is done before. The planification is time-consuming, and it needs some experience, as taught by Professor Ali. These are some results in 3D. You see the cornea before and after. And why we have this distortion of the cornea remaining after the surgery? Because the planification is done to have a regulated on the optical, on the diameter of the pupil. So we don't need to regularize the periphery because it's not important. We see the mesopic pupil, and if it is not very high, we can have this distortion. It's no problem. And when you do corneal wavefront guided treatment, the posterior surface it treats. You have some distortion in the posterior surface that treats partially the keratoconus. So we don't need to have a flattened anterior surface after the surgery. So these are some examples. We have before and after, and you have the PSF before and after, and the quality of vision and the differential. These are some other cases. Before, after. And you can do it in a cornea that had already intracorneal rings, but you have to make sure that the ring is deep and you have good tissue in front of the ring, and to avoid the extrusion of the ring. So though sometimes we go with some very small optical zones, and we can concentrate the treatment to avoid rings extrusion. Before, after a case of ring. We have this case, clinical case, donc 27 years old, visual acuity before surgery, 2 out of 10 in both eyes. Corrected is 6 out of 10, and in every case we do a contact lens test to see if the posterior visual acuity will be good. So this is the topography and the pupillography, we do it in all cases. And this is a corneal wavefront, a total corneal wavefront. And we planify our treatment. Corneal wavefront, we choose the cylinder, the technique, the epithelium. I choose the thicker epithelium in this area, and I put the same epithelium in the center and the periphery to have a PTK effect. This other eye. This is the profile. We choose our optical zone, and we can treat all the aberrations when we can, and sometimes we should reduce automatically, but minimize depth or minimize plus, or with choosing some most important aberrations, and this is the part that needs some experience. I'll go fast. So this is the plan, the treatment, and we have the post-surgery keratometry 47. This is good keratometry. The result is before after. So we went from 6 out of 10 to 10 out of 10 with a very small refraction, and you see here the differential we treated the cylinder and the high order aberrations. Another case, so about 467 eyes treated. We have regulation of the cornea, we have better visual acuity, and reduce of the high order aberrations. And we have some cases of not improvement, so due to some haze, but lots of cases, most cases, there were a very good improvement. And it is the first line treatment in keratoconus patients. In every case, I try to do PRK then rings. I put rings when I cannot do the PRK, and the rings maybe just a step of the treatment, then to come back to regularize with corneal wavefront guided. It is precise and long-lasting results, and I thank my team for their work, and thank you very much.